So we're going to talk about cryotherapy here. It's actually nice to follow Dr. Lucia's talk because a lot of my slides I can just get rid of and we're going to blow through. We'll talk a little bit more about some of the stuff that he presented. I look forward to the talk. So I call it organ preservation in the management of prostate cancer. You know, focal therapy, I don't know exactly what the definition of focal therapy is, and you'll see in here Steve Jones and I tried to write a paper to try to get us all using the common terminology, but really what we're trying to do is organ preservation here. And so that's what it is. The overarching theme of prostate cancer in 2018, we know that just as failure to undertreat potentially lethal prostate cancer, as we've shifted to doing more prostate surgery and higher grade tumors where we might have failed, quote, failed before, just as undertreating those potentially lethal prostate cancer tumors is not considered appropriate, so is overtreatment of lower risk prostate cancers. And we all know that we want the holy trinity of prostate cancer therapy, which is eradication of the cancer, maintenance of urinary function, and maintenance of erectile function. And we heard earlier in this this weekend's events that this is probably achieved in about 40% of patients. So it's a very low number that we actually achieve the holy trinity. And we've seen the evolution of organ preservation. This is nothing new to any of this community, any of the audience members here. But I also would tell you to go back and look at the literature that was coming out at the time of any of these evolutions, and there was great resistance to going from complete mastectomies to lumpectomies to even smaller versions of it. Way back in 2002, Dr. Zink and I wrote an editorial comment on a paper that came out in the Journal of Urology where they were doing radical nephrectomies for tumors that were about 4 centimeters. At the time, we were still doing, a 4 centimeter tumor in a kidney, we were taking out the whole kidney, and that was still considered appropriate. And it was very hard to get us to go to this partial nephrectomy concept. So today, if you were to do a radical nephrectomy for a 4 centimeter tumor, it would be considered inappropriate in the vast majority of cases. So there is an evolution, and there's always resistance to an evolution in going from a whole gland therapy to an organ preservation therapy. Part of the problem with prostate cancer is in going to this organ preservation is we're unclear on exactly what our objective is. Is it an objective to completely eradicate all the cancer? Is it a functional control or functional objective? A lot of these things become very murky when we start talking about prostate cancer. And as we've discussed all weekend long, just how much you have to get rid of the tumors, how many of the tumors are really significant. And we just talked, as Dr. Lucia just talked about, the problems, the ascertainment problem with the random systematic prostate biopsy. So you have to remember there's been an evolution in focal therapy over the past 15 years. When we first started off doing focal therapy studies, we were really dependent on this type of information to move forward. And we know, as we've discussed, the multifocality of prostate cancer. We see the significant bilaterality of prostate cancer, even when you have only unilaterally positive biopsies. We looked at this before doing our first focal therapy trial at MD Anderson, in which we took patients, let's see here, we took patients who had a unilaterally positive for prostate cancer, patients who were biopsied at MD Anderson were unilaterally positive for prostate cancer, and 180 of those patients went on to prostatectomy at MD Anderson, in which we do hole mounting and mapping out all of the tumors, just as has been discussed before. This is the numbers that we found, 3 tumor foci, total volume. Unilaterality, though, even though it was a unilaterally positive biopsy, was present in only 17% of these patients, 83% of them having bilateral disease despite having a unilaterally positive biopsy. So that posed a real problem whenever we went to go forward with our first focal therapy protocol, in that the IRB wanted us to address this type of issue. And so, as has just been discussed, the group in Colorado came up with this, and it's funny that I use the term battleship also, and it's the first time that I've seen Scott used the term battleship, but it really was a battleship approach. And I had a lot of problems with this because, as we've discussed earlier, there's a lot of deflection of the needle, even though you may be advancing it straight through a grid and trying to hit a battleship, just like you played when you were a kid. You see deflection of the needle, as Dr. Stone has talked about earlier. You see swelling of the prostate as you go through. When you start poking the prostate with 100 needles, the prostate size literally changes from the beginning to the end of it. You see movement of the prostate. The Colorado group has a nice model in silica where they have the prostate very well fixed in place, and so you can advance the needle in and out, and the prostate is always there. But in reality, the prostate moves as you hit it with the needle. The prostate, as you breathe, is moving. So this whole concept of being able to so precisely sample every single area of the prostate didn't seem to add up to me in the real world, and that's why we went to some other means for looking at our focal therapy. The other thing that I would say about this type of approach to it, and just because I was watching CNN this morning, and as you know, we brought down a lot of very precision bombs onto very precise targets this morning, and that's what we're trying to do with focal therapy and with our biopsies, is to hit the needle right on target, while the Syrians threw up a bunch of metal up into the air just to see what they would hit. And I sort of look at this approach of doing 100 biopsies of the prostate as the Syrians throwing up a bunch of metal into the air and seeing what you hit. So the purpose of them doing this type of thing was to try to do the targeted focal therapy, and as was just discussed, they actually had 62 subjects that they reported on in this targeted focal therapy. They used cryotherapy and performed a 12-month biopsy. And what was interesting, as Dr. Lucia just pointed out, was the initial biopsy was this very detailed, 100 core or 60 core on average mapping biopsy that they performed at the beginning before doing the targeted focal therapy, but then their follow-up biopsies were our random systematic biopsy. And so despite having less biopsy samples in their follow-up, they still had about a 25%, now it's up to that, failure rate to have from just an oncologic standpoint. So you had less sampling than you did prior to doing focal therapy, and you still had about a quarter of patients having histological disease within an area that you treated with a targeted focal therapy. So that again really bothered me about us trying to go forward with a targeted focal therapy. And in a second, as Dr. Lucia just pointed out, I'm going to probably explain why that occurred. We're going to go through this, the index tumor theory, the multiclonal, intraprostatic lesions appear to be multiclonal, whereas metastatic lesions appear to be monoclonal, and that's really the basis for the index tumor theory, is that you have a single set of cells within the prostate, or a single set of cancer, a single area of cancer within the prostate that all have the same genetic predisposition, and it may not be the same genetic predisposition that the other multifocal tumors have. Thus, the index tumor lesion is really what has driven a lot of focal therapy. So when we, as I mentioned before, we started up our study at MD Anderson to do index lesion elimination, and when I went to the IRB with my data on the where the biopsies, if we did a unilaterally only positive focal therapy and a hemiablation, what would be the results? And this is how we developed the hockey stick thing, because if we did just a hemiablation, we would see that we would only treat 17% of all the cancers within the prostate. Now remember, this was back in 2006, 2007, whenever I was trying to get this through the IRB, and they said that's not good enough, we need something better. And so by going over to the hockey stick formation here on the right, we see that we actually get about 100% of the index tumors, because a lot of the tumors that were being missed were in that anterior zone that was being missed with our standard biopsies. Now this was all done prior to the era of imaging, which I'm going to eventually get to. This is the attempt that Steve Jones and I tried to put out there of using common terminology. As we started reporting on focal therapy series, it became important to describe what we were all doing and to use the proper terminology. So this is what we had with our MD Anderson trial that we reported. These were our qualifications to come into the trial. So we did allow 3+4 disease in there. We had to have a confirmation biopsy. At the time, this was before we had all of the fusion technology. I went to this company called 3D Target Scan that some of you may have used. And the reason we went to this was because as we tried to get this into a multi-institutional type trial, we wanted to take the intraoperative variability out of the prostate biopsy. There's many reports out there that the person who's doing the biopsy influences the findings on the biopsy tremendously. It also, much like Peter Pinto talked about yesterday, it forced us to better sample the entire prostate, I felt. And I still feel, just like reports are now coming out, that even if you do a 12-core prostate biopsy, random biopsy, using one of these devices, you get away from calling an area left, lateral mid when it's actually the base area. And so you get away from oversampling and undersampling regions. So that's why we went to this at the beginning. We used a hockey stick template, as I just described, and the reasons for it. And what's interesting about our study is that we had patients who came in with their initial random systematic biopsy. We then did a confirmatory biopsy using the 3D target scan. They then, if they qualified, would move on to focal therapy. We then performed 3 biopsies after the focal therapy, all using, at this stage, then we were using the Artemis device to perform 3 biopsies afterwards. So it's a really heavily biopsy population there. 72 men were screened, 47 underwent confirmatory biopsy. In the end, we only ended up treating 23 men with the regional hockey stick, and as I just mentioned, our biopsies after each interval here. Whoopsie. And what we found, despite all of these biopsies and doing that 3/4 hemi-ablation, this is what we were talking about earlier, we did 3/4 ablation of the prostate. We found a single patient, it was literally the very last patient, who had a 1 millimeter positive biopsy within field, and that it had therapy effect there, that we didn't go on to treat. So despite, all of these biopsies, that's all we could find by doing 3/4 ablation. And what was very important was that we had excellent preservation of both sexual function and urinary symptoms. We had 0 urinary incontinence, we had a decline in erectile function, and then return to almost baseline in the vast majority of patients. So this comes back to that argument of, can I get away with, doing 3/4 ablation? If I have this good of functional control, and I just showed you that we did, in those 27 men, we did 3 post-operative, post-procedural biopsies, and I'm getting this good of control in both oncology and functional outcomes, do we need to go backwards to doing an even more targeted focal therapy? I'm going to move on real quickly. This is HIFU. Ahmad saw the same sort of decline in erectile function and then return of erectile function that we saw. He was using HIFU at the time. And then along came multiparametric MRI. And this started to change things in how we approached doing focal therapy. And we started trying to target just the areas that we were seeing with the MRI. And what we could see is we could start to do focal therapy on patients where you could actually see the tumor and then see the follow-up of the images. You could see where the tumor used to be, where the shrinkage was, and where, from the T2 and the DWI imaging here, or the ADC imaging here, you see the dropout of where you treated. Same sort of thing here. You can see, even with the blood flow, disappearance of the lesion of the blood flow there. And so this started to change things, and we started to feel that we were doing better with our cryotherapy here. Again, another series of pre and post images in which we can see the area that we were treated. But we have to be careful of what we're looking at, as we've talked about before and as Dr. Stone has said, because sometimes what we, whoopsie, let me go back. Sometimes what we think we're looking at isn't always exactly what we're looking at. And this is a slide that I've been using since about 2008, so I apologize if some of you have seen it over and over again. But it is really the case that you have to be careful. This group looked at whether treatment of a smaller treatment field lowered morbidity, and essentially it didn't seem to change the morbidity. If you decreased, as I was saying earlier, if you decreased the treatment field smaller and smaller, depending on what device you were using, or not depending on what device you were using, no matter what device you were using, it didn't seem to improve the functional outcomes. So one of the issues that we then came into with the MRI was we were treating just the areas that we could see, and as Dr. Lucia just pointed out, we then started discovering that what we were seeing was not really representing what was going on in the prostate. And so while people started looking at treating just the tumor volume itself that was seen on MRI, we were still having significant failure rates, which I think is part of the problem with what happened with Dr. Crawford's original study in doing targeted focal therapy and having such a high positive biopsy rate after that targeted focal therapy, is that the disease was much more extensive than they could really appreciate, either by imaging, which they were also using, or by their very extensive transperineal mapping biopsy. So this is a very nice article in which it looked at the size of the actual histology by comparison to the MRI itself. And you can see, depending upon the axis, there was a difference in how much the tumor extended beyond the margins of what you thought it was on the MRI compared to what you saw in histology. And in particular, in the base to apex, there seemed to be the greatest amount of error in the estimation of tumor volume in the base to apex region compared to any other. So a lot of people have looked at what should be the appropriate margin around the prostate here. Laban said it should be a 9 millimeter margin. If you just sort of summarize a lot of the data, it goes anywhere from 5 millimeters up to 9 millimeters, so should be the appropriate margin around any tumor that you're targeting, which, you know, gives us a big area there beyond what we're seeing on MRI. So as was just discussed, I do have some concerns about doing just image-guided only targeted ablation, no matter what the tool. I'm going to go through this real fast here because this is supposed to be on focal therapy. This is what I was going to get rid of. So the one study that I wanted to talk about, and I have to thank my colleague, Dr. Ukumori, who was at USC and is now in Kyoto, Japan. And Dr. Ukumori has shared his updated presentation with me. I think it's one of the best series that was that has been presented. So this was their original paper that they showed with 73 men and 3.7 years of follow-up, showing a decrease in PSA and compared to the radical prostatectomy. The updated one, which they're just starting to report on now, they have 180 patients as opposed to 73 patients, so they've over doubled their total patients here. They use a freehand technique, truss, with 2 freeze-thaw cycles. Dr. Ukumori has a very unique way of doing it in that he essentially brings the needle in parallel to the neurovascular bundle rather than having it go straight, if I can get my arrow, rather than having it go straight into the prostate as we're generally like to do. He likes to bring it in parallel to the neurovascular bundle, feeling that it conforms to the ice ball, conforms to the prostate a little bit better. And then they perform follow-up with 3, 6, 12 months and annually thereafter with a follow-up biopsy at 12 and 24 months. And this is what they're found and that they're going to report. And again, I have to thank Dr. Ukumura for sharing this with me. 180 patients, they saw the time to PSA nadir of about 4 months. The decrease in PSA nadir was 82%, so an 82% decline in PSA nadir. This is sort of the heart of it, is that they did the follow-up biopsies. You can see in the untreated lobe, they still were finding prostate cancers, about 21% of the prostate cancers, and there's more data out there on exactly the nature of these, but these are mostly Gleason 6 prostate cancers, has been discussed, with some Gleason 7 prostate cancers being identified, or 7 or greater, in the contralateral lobe. So again, we're missing things and not completely treating it. Within the treated lobe, however, they had a very low rate of Gleason 7 prostate cancer being identified, but again, it's not perfect. And it gets particularly bothersome, Usama and I discussed this, when you start looking at higher risk patients. So we've talked a lot about taking high risk patients and subjecting them to focal therapy, and you know, the rate of failure goes up to 14%, which may not be acceptable, especially when you have high risk patients. And a lot of this, again, may have to do with, at the time that this study was initiated, not recognizing just how extensive the disease was beyond the margins. This is their functional outcome in this study. Potent men, 62%, or maintenance of potency was 76% afterwards, and then pre and post continence, virtually perfect. A couple of people experienced some stress urinary incontinence there. This is, I'm going to go through that real fast. I think that's, and so one of the final things that I wanted to say about focal cryotherapy, and we've been trying to do this, I can't tell you how many grants I've submitted that have been shot back at me, is doing focal therapy, and especially focal cryotherapy, as part of a tumor-induced immunotherapy. And there has been some work looking at this. This is one of the studies that we got involved in early, in which we had mice with tramp tumors in it, and we're essentially able to treat the contralateral tumor by freezing the one tumor on one side and administering anti-CTLA-4. And so there does seem to be some immunotherapy as that becomes, some immunotherapy effect as that becomes more and more part of our paradigm. So maybe that we can look at using focal therapy as part of a multimodal strategy in which we either deliver some sort of agent to assist in cleaning up these other tumors that we don't get, or my thought is probably on a immunotherapeutic level. So in conclusion, from all of this, what I really wanted to emphasize was that MRI underestimates the size and extent of prostate tumors, and we have to recognize that, and as we've been discussing, move forward with better thought. High Gleason score and tumor size, we need more safety distance. So if you're going to treat higher Gleason grade prostate cancers, you need to give even more of a prostate margin, and especially in that anterior, that apex to base distance. The treatment device may make a difference there. That's it. Oops, I had a slide there, but that's it. Thank you very much for your time.